Thank you, Gail. Thank you, everybody, for coming. It's an absolute pleasure to be presenting on the behalf of the GI Society, which is a fantastic organization which, as you guys can see, is very patient-centered. So, it provides a lot of support and a lot of education and information for you guys. And I learned something new today, that it's as old as I am, so it's young. It's a young organization. I'm Janakie Singham. I'm a gastroenterologist here in Surrey. I do general GI, but I do focus on inflammatory bowel disease. I've been practicing here for about 5 years. I did my medical school at Queen's in Ontario. I did internal medicine here at UBC, and my GI and IBD training under Dr. Bressler at UBC. So I'm going to give a basic overview of inflammatory bowel disease, period, from a physician's point of view. And I'm thrilled to have this opportunity to talk to you guys, because I think the present and the future of medicine really is that we have a team approach with other medical physicians, like our dietitian physicians, but also the patient, such that the more information that you guys have, that's the more power you have to collaborate with your physician to make mutual treatment decisions versus unilateral ones, which is a thing of the past. So what we'll discuss today, we'll go over the anatomy of the GI tract, go over the differences between Crohn's disease and ulcerative colitis, go over the symptoms, which if you guys have been diagnosed, you are more than aware of already. Treatments including lifestyle, medications, surgery, and again, support with, like they talked about, the support groups with psychological help, because having IBD can be a difficult diagnosis. And then you'll have a talk about the diet as well. So what is inflammatory bowel disease? It's chronic inflammation of the digestive system. And there's two different ones. One's called Crohn's disease, one's called ulcerative colitis. If you're symptomatic and you're not in remission with all of the different things we have in our armament, it can be disabling, can cause discomfort, can definitely have a negative impact on the quality of life. And then we have charts that will show you that later. But as mentioned by Gail, very few people pass away from inflammatory bowel disease these days, and that's because of the advances that have been made in both medical and surgical management. So it shouldn't necessarily change your quantity of life. So this just shows that there's two different entities. One's Crohn's disease, one is ulcerative colitis disease. There's another slide that goes over the cardinal differences between the two. So Crohn's disease is bumped gum, can affect any part of the gastrointestinal tract from the mouth to the anus. And one of the cardinal differences is that ulcerative colitis only inflames the innermost layer of your bowels, whereas Crohn's disease inflames all three layers. Most commonly, Crohn's disease affects your lower small intestine, plus your small intestine or your colon, but it can affect other things like your stomach and your upper small intestine as well. Ulcerative colitis can affect any or all of your colon. Again, it only inflames the internal innermost lining of the colon, which is a useful distinction when it comes to the medications that we use to treat it, and we'll go over that when we get to the medications that we use. Indeterminate colitis is when there are features that are consistent with both Crohn's disease and ulcerative colitis, such that it sort of straddles both diagnoses, which makes it a bit more tricky, because planning treatment, you don't know if you should go the Crohn's pathway or the ulcerative colitis pathway. Fortunately, only 10% of patients with inflammatory bowel disease will have indeterminate colitis. So what kind of symptoms that you can get with inflammatory bowel disease, both Crohn's and colitis? You'll get diarrhea with frequent bowel movements. They may be bloody. You can get urgency, where you feel like you need to rush to the toilet to make sure that you don't have an accident. There can be mucus, and what the mucus is a function of is simply inflammation. So that what you're seeing as mucus is pus. Cramping, discomfort in your abdomen, and less likely nausea, vomiting, or loss of appetite. But if those factors are present with inflammatory bowel disease, that suggests that it's more aggressive disease, and it's more severe at the time of the presentation of those symptoms. You can get other symptoms in other parts of your body. You can get skin rashes. You can get inflammation of your eyes. You can get sores in your mouth. You can get joint aches and pains. And there is what we call a waxing and waning course of disease. So there will be times when you're in remission, either spontaneously, which can happen in a very small percentage of patients, or with medications, with then superimposed flares during which you do have active inflammation and symptoms. So this looks at general life satisfaction. And what I love about this is that it shows that we're actually doing pretty good. So the orange-ish line is IBD total. The purple line is Crohn's disease, and then the green line is ulcerative colitis. And normal patients have a life satisfaction of 60 or just above 60 on the scale, and it looks like we're achieving a little over 50. What I found interesting was that people with urological diseases feel better than people who are normal. They like their lives better. But so in terms of differentiating the symptoms between Crohn's disease and ulcerative colitis, abdominal pain, it won't be really pain unless there is a complication like a blockage or an abscess, but that definitely can be discomfort, especially if you do have partial blockages. Ulcerative colitis, again, you wouldn't have necessarily severe pain, but you can have a lot of discomfort when you have a severe flare. Diarrhea is often present in Crohn's disease and in ulcerative colitis when it's not in remission. Rectal bleeding can happen with Crohn's disease if there is involvement of the colon. Like I mentioned, it most commonly affects the lower small bowel. Ulcerative colitis starts at the anus and the inflammation goes up, so you will get rectal bleeding with that. With Crohn's disease, because it affects the small intestine and that's where nutrition is absorbed, you can have nutritional deficiencies, whereas with ulcerative colitis, because the small intestine is spared, it's quite rare to have it. Crohn's disease is common in the pediatric population, so there can be a slow growth. With ulcerative colitis, again, because it doesn't really affect absorption of or digestion of nutrition, because it doesn't affect the small intestine, you rarely get slowed growth with that diagnosis. Crohn's disease can present more severely than ulcerative colitis, so you can get a decreased appetite, you can get weight loss, you can get fatigue, especially if you're iron deficient or vitamin B12 deficient, whereas ulcerative colitis often doesn't present with those features, although when you have severe presentations, they can definitely be present. Fevers with Crohn's disease and ulcerative colitis can occur with severe flares. That is a very severe flare. So if I see that one of my patients has a fever with their symptoms, that means that they do need to go to the hospital. Tenesmus means that you have an irritated sense in your anus that you always have. You feel like you need to have a bowel movement, you go and you only pass nothing or mucus. It's sort of an irritation of the rectum. Because Crohn's disease very rarely affects the rectum, it doesn't often happen in Crohn's disease, but it does often happen in ulcerative colitis because the rectum is affected. Again, mucus, because it's inflammation. Nausea and vomiting is rare. Perianal infections and abscesses, this is a cardinal marker of Crohn's disease, so it will not happen in ulcerative colitis, but can happen in Crohn's. What a perianal infection is, or abscess, it means a collection of pus or an infection right around your anus, and it can burrow into the muscles of your buttocks sometimes, so it can be quite severe. And anemia, which means a low red blood cell count, can happen in both diseases. In Crohn's disease, because you may not be absorbing all the nutrition that you need. Also because with the inflammation, you're slowly losing blood. And with the ulcerative colitis, again, because you're losing blood. Complications of Crohn's disease, because it's a full thickness inflammation, like we talked about, there can be scarring of the entire thickness of the bowel, which can lead to a narrowing and a blockage. Again, because it's a full thickness inflammation, the inflammation can burrow through all three layers of the intestine to break through and create an infection, which is an abscess. And again, because it's full thickness, with chronic inflammation, it can burrow a tunnel between the intestine itself and other parts of your body, like other organs, including your bladder or your vagina, to the skin or to the anus. Ulcerative colitis disease, the complication, there is an increased risk of colon cancer. The 43% at 35 years, that is the data presented right now, but that is in evolution because we are seeing precancerous and cancerous changes much, much less as our treatment gets better. One of the main factors that determines whether somebody is going to potentially develop colon cancer in the future is the degree of their control, because if you keep having inflammation, you're going to keep changing the DNA in your colon lining, which can predispose to cancer. So if you have better control and more remission of your colon, your risk of developing colon cancer is going to be less. And so as our remission rates get higher, our colon cancer rates are getting lower. So diagnosis of IBD, we or your family doctor initially evaluate you. talk about your symptoms, how long they've been, how severe they are, talk about a family history, and it's not just a family history of Crohn's disease and ulcerative colitis that's relevant. Other autoimmune conditions are as well, like psoriasis, psoriatic arthritis, rheumatoid arthritis. You do a physical examination, look for any of those other manifestations of inflammatory bowel disease that we talked about, like the eye symptoms, the joint symptoms, the skin symptoms. You can do a rectal exam to look for any of those perianal abscesses. You get lab tests done, check if you're anemic, check if your inflammation markers are up. You can do blood tests, and you can do stool tests both to rule out an infection as the cause of your symptoms versus something called a fecal calprotectin, which is a protein in inflammatory cells that's shed in the stool when you are inflamed. And so it's a good surrogate marker for endoscopy to see how well you're doing on your medications instead of actually going through colonoscopy. And to differentiate active inflammation in Crohn's disease from other diagnoses like irritable bowel syndrome. A colonoscopy is, a fecal calprotectin won't replace a colonoscopy for initial diagnosis, because even if it's positive, it doesn't tell us the degree of inflammation, where the inflammation is, whether this is Crohn's disease or ulcerative colitis. So this is still the best tool for us to see the surface of the colon, take biopsies, rule out other things like infection. A gastroscopy we don't usually do in inflammatory bowel disease, except in patients with Crohn's disease who do have upper digestive symptoms, like upper abdominal pain, nausea, or vomiting, because the stomach and the upper small intestine can be affected in Crohn's disease, but it's really quite rare. A barium enema is becoming obsolete. It's not even being taught to radiology resident graduates because its sensitivity and specificity is so low. So in a center in the Lower Mainland, it has very low utility, but where it does become very useful is in rural and remote places where they don't have access to a colonoscopy, and so you can get a barium enema, to see if there are any changes that need to be that you need to be worried about. An X-ray is a good test to look for an obstruction, which, as we talked about, can be a complication of Crohn's disease. Ultrasounds can be used for Crohn's disease as well. It's very specialized, and only one, maybe two centers in Vancouver do them, so there's a really long wait list. And CT scans are usually what we go to because they give us very accurate readings about potential complications of Crohn's disease, like the fistulas, like the abscesses, and they're much easier to get than the ultrasound. Only VGH. And I think one radiologist now in St. Paul's does the small bowel ultrasounds. So I think this is a cartoon saying that we're torturing you guys with our scopes. I really do them one after the other, I promise. I don't do them simultaneously. So what factors influence IBD? Genetics is huge, and you'll see a slide that shows that we have found some genes that are responsible. Environment, your immune system, again, it is a disease primarily of the immune system where it's overly active and attacking your bowels. There is some thought that it may be heralded by certain infections. This has not been proven yet. Certainly stress can bring on flares, especially with colonic inflammation, whether it's Crohn's colitis or ulcerative colitis. Diet and smoking can play some factor, especially smoking, and especially when it comes to Crohn's disease. And we'll talk about that in a different slide. The microbiome is a very important player, and what this means is the makeup of the bacteria in your bowels. So it's the diversity of the types of stool you have, how many different species of stool you have, and what types you have. And that's very individual and very much like a thumbprint. And really, that is how diet can affect Crohn's disease and ulcerative colitis by potentially altering your microbiome. That's how smoking is potentially causing, contributing to inflammatory bowel disease. And that's probably where environment has a factor as well. Medications, obviously, because we do treat Crohn's disease and ulcerative colitis. Lifestyle, I'm not sure what they mean by that. I mean, there's no real evidence that things like drug use or anything makes it worse, but I would discourage that anyways, so. Genetics and IBD, these are a list of the genes that have been shown to be linked to both inflammatory bowel disease. The problem with this is that what we call the penetrance is incomplete, which means that just because you have one of these genes mutated doesn't mean that you're going to have Crohn's disease or ulcerative colitis. And having Crohn's disease or ulcerative colitis doesn't mean that you're going to have one of these genes that are mutated. So again, it comes back to this being a multifactorial disease where some people who are genetically predisposed, when presented to the right environment, when presented to the right or wrong microbiome, will then develop Crohn's and colitis. And this is sort of a deviation from this slide deck, but one thing that's interesting is that one of the reasons I have such a big Crohn's and colitis, especially ulcerative colitis patient population, is because I work in Surrey, and there's a huge Punjabi population here. Colitis is not common in third world countries, including India. It is also not common in adults who move to first world and Western countries. But second generation or children who move to first world and Western countries, in some patient populations do have an increased risk, and Punjabis are one of them. So their parents will be fine. They will have no family history of ulcerative colitis. And I have probably the most of my ulcerative colitis patients are Punjabi patients. So again, obviously there's a genetic predisposition in that Punjabi population, but there's something about the Western environment, whether it's too cold such that we're killing off the bacteria so that the diversity of our microbiome isn't high, whether we're too clean as children, we don't run around on the floor and lick the dirt so that our microbiome doesn't have as many or the right type of bacteria, or if it has something to do with the Western diet, in terms of processed foods, killing off the right bacteria or creating certain pro-inflammatory factors. So stats in Canada. Canada has the highest prevalence and incidence in the world of both ulcerative colitis and Crohn's disease. There is a north to south predisposition, so countries that are further north have greater incidence and prevalences than further south, and Western and First Nation countries have a greater incidence than third world countries. So you put them both together, Canada, we're pretty far north, we're pretty westernized, we have the highest. There's 233,000 patients living with inflammatory bowel disease, and there's the breakdown for you and how that works. 10,000 new cases every year, 5,700 Crohn's disease, 4,500 ulcerative colitis, 5,900 children have inflammatory bowel disease. It is quite commonly diagnosed in children, teens, and in their 20s. And again, we talked about the elevated risk of developing colorectal cancer, but that we may be winning the battles there. And if not treated, there is an elevated risk of premature death in the general public as well. So this goes back to what I just said about when you get the symptoms, when you get the diagnosis. The majority are in their teens and their 20s, still pretty high in the 30s. Then there's a second peak in the fifth and sixth decade, and then it drops down afterwards. So why inflammation? This is a very complicated answer, which you could probably write your thesis on. The digestive system is one of the few systems that tolerates bacteria. If you inhale bacteria into your lungs, you will get a pneumonia. If you have bacteria in your bladder, you will get a bladder infection. Whereas there is 1 trillion bacteria per 10 grams of stool, and you don't mount an inflammatory response. And that's because there's various mechanisms. The mucus, there are bacteria that actually fight infection by producing certain defensive mechanisms. The lining of your colon itself has a lot of defensive mechanisms so that you can tolerate that bacteria without mounting an inflammatory response. What happens with inflammatory bowel disease is that mechanism of tolerating the good bacteria goes awry, and you get inflammation. So smoking and inflammatory bowel disease, with Crohn's disease, not only is the incidence higher with smokers, it's more difficult to treat in smokers. You get more complications like the blockages, the abscesses, the fistulas if you're a smoker. And after surgery, there's a greater risk of postoperative recurrence in smokers. Ulcerative colitis disease, with current smokers, they rarely get it, but ironically, people who smoke and then quit oftentimes will get ulcerative colitis a few months to a year later. But that doesn't mean that you guys should start smoking. So degrees of ulcerative colitis disease, proctitis means that just your rectum is involved. It's not necessarily easier to treat or easier to handle in terms of symptoms. The only benefit would be that if you have proctitis, which means less than 30 centimeters of your colon affected, you do not have an increased risk of colon cancer compared to the general public that does not have ulcerative colitis at all. Left-sided colitis goes up to where your spleen is, okay, so about the bottom 30 centimeters. That's the most common, so about 50% will have just left-sided colitis. Pancolitis means that your entire colon is involved. That does mean that your disease is more aggressive, that it's likely going to be more difficult to treat and bring into remission, and that does increase your risk of having colorectal cancer. The percentages are that 50% of people will have left-sided colitis, 30% will have proctitis, and 20% will have pancolitis. So what this is something called a Mayo score. It's a tool that we use to see how well in remission our patients are. So normal bowel movements generally are between 3 times a day to 3 times a week, but that's very variable. I have a very good friend who has 1 bowel movement every 2 weeks and feels fine. I think she's weird. Mild is 1 to 2 more than your baseline. So if your baseline is 3 and you're having 4 to 5, that's abnormal. If your baseline is 1 bowel movement a day and you're having 2 to 3 bowel movements or 3 to 4 bowel movements, that's abnormal. So that's all based on your baseline. 3 to 4 is moderate, greater than 5 is severe. Rectal bleeding, if you see none, that's a good sign that you're in remission. Streaks of blood suggest that it's mild. Obvious blood suggests that it's moderate. If all you're passing is blood, that's severe. Visual assessment, so this is with a sigmoidoscopy or colonoscopy. If it's normal, then I know that you're in remission. So what friable means, it's not really crumbly, but it means that it's very susceptible to the slightest stimulation. So if I just slightly scrape it with a biopsy forceps, whether it bleeds, whether it gets damaged. So with mild, it's only mildly friable. With moderate, even slight pressure will lead it to bleed. And with severe inflammation, there'll be spontaneous bleeding. So this is an interesting slide because it shows that how different patients perceive their symptoms versus doctors and nurses. Where of this cohort, 53% of people thought that they had moderate inflammatory bowel disease, and 32% thought that they had mild. And while severe, the doctors and the nurses could agree upon, more doctors and nurses would classify them as moderate versus mild. So this is a reminder that we may be underestimating your symptoms. So, if you're worried about your symptoms, talk to us, tell us why you're worried. If there are factors that we are not worried, we can then explain them to you. And you may be alerting us to something new, such that we say, oh, well, I didn't realize that you were having 6 bowel movements a day instead of your usual 3, so maybe we should, do some more investigations to see if we do have you in remission. And this is what that says. It says, be vigilant. Like I said, this is a team approach. The more you're engaged in your own management of your disease, the more successful we both will be in achieving remission and keeping you there. So note any changes, keep track of your bowel movements, keep track of whether there's blood or not, and communicate with your physician. My nurse, Sonia, is right there. She'll call you and talk to you and tell you that she's worried about you or not. Medication goals. So what we want to do is look for the best long-term treatment options to maintain you in remission, to both prevent complications and to maintain quality of life and quantity of life. Limit the use of steroids, and that is because steroids work great for inflammatory bowel disease, but they have significant side effects, more side effects than the other medications we use, like the biologics. And so one of our treatment goals is always to have you on as few courses of steroids during your lifetime with inflammatory bowel disease as at all possible. Mucosal healing is a target for our treatment always, because it means that we can achieve longer periods of remission. There's less risk of complications and needing surgery. You have fewer symptoms, and as I mentioned, inflammation and ongoing inflammation is the one thing that correlates the best with an increased risk of colon cancer. So again, achieving mucosal healing in ulcerative colitis will mean that we're seeing colon cancer as a result of it less and less. So symptom control, you can use pain control medications, antidiarrheals, antispasmodics. We don't recommend any of those because they mask the symptoms. They're only a Band-Aid, and sometimes they can increase the risk of complications. Both antidiarrheals and narcotic pain control with ulcerative colitis increases your risk of a life-threatening complication called toxic megacolon. And again, we don't want to just put a Band-Aid on things. We want to get to the root cause of it and treat the cause instead of just treating the symptoms. Probiotics. So we talked about the microbiome, and the objective here is to change the microbiome to something that's favorable. BSL-3, and actually it's E-Nissl is the other one that has been tested for Crohn's disease and ulcerative colitis and shown some benefit. Lactobacilli and bifidobacteria has more been tested for irritable bowel syndrome and found to be beneficial. Unfortunately, the studies were quite small and fraught with a bit of bias. So we can't recommend it as monotherapy. We can only recommend it as in conjunction with other medications. And the problem with the probiotics is that they are expensive, and most third-party health insurance won't cover it because there's no evidence of benefit. So they won't, pay for medications that they don't think is going to work. So here's all the medications available for symptom control. So medications, 5-ASAs are preparations that you can take as a pill or as an enema or a suppository. What they do is they coat the colon to decrease inflammation. We talked about how ulcerative colitis involves the innermost layer only. So this is a great strategy for mild to moderate ulcerative colitis, where it will just coat the colon, decrease the inflammation, doesn't get absorbed into your bloodstream. And so the side effect profile was not greater than placebo, okay? Because it's not getting absorbed, it's not going to different organ systems. And it's useful for induction and maintenance of remission, again, in mild to moderate disease. In moderate to severe disease, simply coating the colon is not enough. The inflammatory burden overwhelms just coating the colon. And in that case, you will need to progress to medications that suppress your immune system, since it is your immune system that's overly active. Sulfasalazine is 5-ASA plus a sulfa moiety. The sulfa moiety initially they thought wasn't an active ingredient and that it was just used to deliver the medication through to the colon where it can be released and coat the colon. But the sulfa itself caused a lot of side effects, including things like the headaches, the loss of appetite, and the nausea. So it has fallen out of favor quite a bit because of that, because we have other 5-ASAs that do travel to where we needed to go to get released there without those side effects. But it is quite useful with joint aches and pains, which can be quite a problem for patients with Crohn's and colitis. Antibiotics like Flagyl, Cipro, they can be used for complications such as abscesses around the anus like we talked about. And they're sometimes used for postoperative recurrence and as adjunctive therapy for Crohn's disease and for something called pouchitis, which is inflammation after you have ulcerative colitis pouches, but that's very specialized. That's something that only a handful of patients will need. And obviously we shy away from using long-term antibiotics because we're killing off other good bacteria when we're using it. So steroids are immune suppressants. I tell my patients that using a steroid is taking a machine gun approach. It knocks out all of the immune-mediated mechanisms as well as others in your body. It has potentially serious side effects, including weight gain, osteoporosis, glaucoma, which is high pressure behind your eye. High blood pressure, it can cause weight gain, rounding of the face, acne, cataracts. It causes mood lability and depression, sometimes suicidality. Side effects increase with longer usage and higher doses, and there's simply no evidence that it works for anything but induction. So they did try to use it for maintenance therapy even at lower doses, and it simply does not work. So immune suppressants, azathioprine, cyclosporin is really not used anymore except as rescue therapy in patients with severe ulcerative colitis. 6-MPA-methotrexate, these are more targeted than steroids in terms of suppressing your immune system. They can wean you off of steroids. Anytime we use a medication, we always look at the risk versus benefit ratio. And the benefit, especially with ulcerative colitis, is based, again, on very small studies and older studies, and newer studies shows that it may not be effective, whereas the risks are there, including increased risk of certain cancers and infection. So most gastroenterologists don't use it as monotherapy for ulcerative colitis unless the patient has already been well on it for the last 20 years. It's still quite useful in Crohn's disease, and it's still quite useful to use in combination with biologics, because the biologics are foreign proteins administered to your body, which means that your immune system is going to develop antibodies to these proteins to chew it up. And so we use these medications not so much to actually treat the disease, but to prevent that antibody formation. And that can potentially be used in lower doses than you would use for actual treatment of the disease. So these are the biologics. Like I said, moderate to severe ulcerative colitis and Crohn's disease. Infliximab and adalimumab can be used for Crohn's disease and ulcerative colitis. Golimumab, ustekinumab is used for Crohn's disease only at this point, but you do need compassionate release, so it's not a first line. And vedolizumab can be used for ulcerative colitis only. These are more likely to heal the mucosa, which mean that going back to when we said that that was one of our targets, it means less surgery, less complications, less colon cancer, and better quality of life. There is an increased risk of infections, particularly sinus disease, sinusitis, pharyngitis. There are other side effects as well that we can talk about if you guys want to at the question and answer period. There is a slight increase of something called lymphoma, and there's a slide on that, which is a type of blood cancer. So those are the pros and cons. And again, we always weigh out the risks versus the benefits of using any of these medications and individualize that to each patient. So each biologic approved for Crohn's disease and ulcerative colitis, it has its own patient support program. It will help you with insurance. These are very expensive medications, but despite my large patient population with inflammatory bowel disease, I really don't think that I had had anybody not covered. And Surrey isn't the most wealthy demographic, and I do have patients on disability and welfare, and I've still been able to get them covered for it, and patients with low incomes covered for it, even if they're not on welfare. It will remind you of your appointments, about your doses. They can hook you up with other patients so that you can talk to them about it, support groups, et cetera. Can give you tips in coping with your condition. I know that sometimes they give out cookbooks and things like that, if you ask. So could a biologic be the right medication for you? It depends on what kind of disease you have. If you have mild to moderate disease and it's ulcerative colitis and the 5-ASA is working, no, it's not. I would much prefer to keep my patients on a medication that keeps them in remission with no side effects. But if you're failing 5-ASAs, or if straight off the bat you have severe disease, things that we talked about where you have deep ulcers, or you have weight loss, you have a low appetite, you have fevers, you have severe disease when I do the colonoscopy, you would be a candidate to start it, because I already know that using a 5-ASA is not going to work, and I'm just going to be wasting time and keeping you potentially open for a complication or needing surgery while screwing around with a 5-ASA. And we talked about combination therapy is essentially standard of care, I would say, currently with IBD specialists, because we do want to maximize the effectiveness of your biologic without increasing the dose or increasing the frequency by decreasing the antibodies that you potentially can make to them. And you don't need to be on that combination forever. So the period where you have the greatest risk of developing antibodies to one of the biologics is 1 year. And after about 2 to 3 years, it decreases dramatically. So, you can potentially stop it in 1 year, and in 2 to 3 years, you can cut it in half and then stop it completely as well. So this is the risk of cancers and non-Hodgkin's lymphoma. The green are people with inflammatory bowel disease and who are on one of the biologic therapies. The blue are people who are not on any biologic, and the red is the general population. So as you can see, the patients on a TNF with inflammatory bowel disease, their risk of non-Hodgkin's lymphoma is higher than if you're not on a TNF. But cancers from all other causes are significantly higher if your disease is not controlled by not being on an anti-TNF than if your disease is controlled by being on a TNF and then dying from a car accident. Very common, unfortunately. What this slide says is that you can't treat the disease if you're not on the medication. So, continue to take the medication even when you're feeling well. It is a control. It's not a cure. We don't have a cure quite yet. Ulcerative colitis technically has a cure, which is surgery, but it's obviously something, especially in our young patients, that we would prefer to avoid, and Crohn's and colitis patients are young. It decreases the risk of flare-ups. It decreases the risk of complications. Again, I'm going to deviate a little bit. This is a study that I quote my patients when they ask me when they can come off of the biologic. And there was a study that took many hundreds of patients who were in what we call deep remission, which means that their blood work was normal, their symptoms were gone, they did a colonoscopy and that was normal, and they took biopsies and that was normal. And they stopped their biologics, and about 70% reflared within the first 8 months. And of those, 20 to 30%, you could not recapture the same level of remission with the same medication that you used before. So for those 20 to 30%, you took something that was working and broke it. So as things stand, we recommend that you stay on the medications. So this just shows the different things that we can use to monitor the natural history and whether you're flaring. Obviously, we use symptoms. We use a blood marker called CRP, which is a marker of inflammation. We can use colonoscopies, and we can take biopsies from the colonoscopies to assess for whether there is active inflammation or not. So monitoring the disease activity, certainly there are great resources from the GI Society. Therapeutic drug monitoring is a very complicated topic. If you guys want to hear about it, I'm happy to talk to people at the end of the lecture. It's the future of personalized medicine. It's where we monitor how you're responding to the biologics, how quickly you are metabolizing the biologics, and whether you're producing antibodies to predict who's going to respond and who is not, and to change the dosing, the frequency, or the medication according to the individual patient versus trial and error. And then fecal calprotectin we talked about already. That's the stool test in terms, again, it shouldn't be used for colon cancer screening or surveillance. It shouldn't be used for first diagnoses, but it can be quite useful in assessing whether a patient is in remission and to monitor whether they have ongoing inflammation even if they're feeling well. So surgery obviously carries its own risk and can impact the physical and mental well-being. If you need it, you need it. And if a gastroenterologist recommends it, it means that you have failed medical therapy and there's nothing more that our medications that can give you. But we would always prefer to avoid it and treat you with medications instead. Reasons for that, sometimes involves an ostomy, which is a bag. Even if you get an internal pouch, it does mean frequent bowel movements throughout the day and nocturnal bowel movements. And especially in females, it can alter your fertility, which is obviously an issue when the majority of our patients are in their teens, their 20s, and their 30s. So this just shows that, having ulcerative colitis or Crohn's sucks. You're having these symptoms in your teens and your 20s, you're on these medications, you're getting colonoscopies, you're getting all this blood work. And as I mentioned, stress can affect inflammation in the colon. I had one patient who had been in remission for decades, and then she had a divorce, and she ended up in the hospital with a severe flare. So, always look for support groups, like the ones that the GI Society provide. Talk to people, whether it's family, friends, clergy, counselors, etc., because mental well-being is a big part of treating this disease as well. And it's also why irritable bowel syndrome symptoms are really quite common with inflammatory bowel disease. For one, there is the psychosocial stress aspect of it. The other is that we know that inflammation of the digestive system with a transient infection, like if you go to Mexico and you get 10 days of diarrhea, can then lead to chronic symptoms even after the inflammation is healed with post-infectious irritable bowel syndrome. So if that can happen after 10 to 14 days of inflammation with an infection, you can imagine what the many months of inflammation with inflammatory bowel disease can do in terms of affecting the nerves that go to your digestive system, affecting the motility, and leading to irritable bowel syndrome. So these are just some goals in terms of how to stay mentally healthy. Do exercise. I'm a big fan of meditation. You can call me a freak. It helps me sleep. Spread out the activities. And then adding the muscle and bone strengthening activities, that's really important if you've had multiple courses of steroids. Again, it's our objective to avoid that at all costs, but sometimes it's necessary. Sometimes it's already happened by the time you get to a gastroenterologist or an IBD specialist. And these are all of the different things that you can turn to for emotional support, I think much of which I have talked about already. And this is the dietary talk.
Hi, everybody. My name is Anne-Marie Stelluti, and I'm one of the clinical dietitians at Mount St. Joseph Hospital. I've also worked at the Montfort Hospital in Ottawa. I went to school at McGill, and IBD has always been a particular passion of mine because I think there's so much that nutrition has to do with it. So I'm really happy to be here today to talk to you about this. Let's get started. So at this point in time, no direct relationship has been proven that food causes IBD or that food cures it. That being said, they've done a lot of research, and there are foods typically consumed in our Western diet that they've had links, but again, nothing proven. So foods high in red meat, low vegetable and fruit intake, or high simple sugar intake have been some links. Currently, the role of nutrition is really focused on enhancing your nutritional status, so having a strong immune function, promoting wound healing if you need it, if you need to maintain a healthy weight or even gain weight. And quality of life is really important because we want you to have a healthy and positive relationship with food and continue to enjoy all the social activities that go along with it. The other important part of nutrition is on the dietary management of symptom control. So if you are having bloating or cramping or loose bowel movements, there are a lot of things with diet that we can do. And please remember that the location of inflammation is important because, like Dr. Singham said, different nutrients are absorbed in different areas of the body. So for some tips for IBD, there really is no one diet. Everyone is different. It's very individual. If you're having a flare, it's going to be different than when you're feeling well in remission. If there's certain medications you're taking or your lifestyle, again, it's going to be different. We do encourage that you eat a variety of foods from all the food groups. Here's a picture of Canada's food guide right there, just to make sure that you're getting all the nutrients that you need. Some people feel better having smaller, frequent meals in the day, 5 to 6 meals a day. Others have no trouble having your three meals a day. So really, it depends on you. We do recommend that you limit foods that would make your symptoms feel worse, which I'll talk to you soon. And if you do tolerate the food, please eat it. Just pay attention to your own body because you know it better than anybody else. Slowing down and taking your time to eat is really important. Avoid eating on the go, eating on the run if you're on the bus, and just take the time to chew very well. I know this sounds silly, but I did meet a man once who would eat oranges whole with the orange peel, and that's difficult for anybody to digest. He thought it was normal. So pay attention to the food that you eat. If you do tolerate foods high in fiber, especially when you're feeling well, that's great. There's a lot of health benefits associated with it. And you may need to take a daily multivitamin with minerals as well. So when it comes to symptom control, we strongly recommend that you keep a food and symptom journal. This can be written down, either having the date, the time, the food, amount eaten, any symptoms you may have, of course. Other factors like mood, stress, or medication are important to note down. There is the GI Bodyguard, which was an app that was created by the Canadian Digestive Health Foundation, which is an easy thing to just write down what you're eating, and you can also mark down your symptoms as well and show your gastroenterologist. A dietitian can really help you analyze your journal, identify triggers, foods that may be causing certain symptoms, and modifying your diet accordingly. If you need to avoid something, maybe you can supplement it with something else to get all the vitamins and minerals that you need. And we really work together with you as a team approach. We're not telling you what to do. It's really working together to create a plan that is realistic and fits your lifestyle. So during a flare, there are certain foods you may need to avoid, and these restrictions may just be temporary. Fatty, greasy foods are one of them. Alcohol and caffeine both stimulate the intestine to work faster. That can contribute to loose bowel movements. Sweet, sugary foods have the effect of drawing water into the intestine. That can contribute to loose bowel movements as well. Lactose is the sugar found in milk. It's a natural sugar. They haven't shown that lactose intolerance is more common in the IBD population, but it can happen, and sometimes just during a flare. There are a lot of lactose-free products available, and what would happen is, say you drink a cup of normal milk, you may have bloating or loose bowel movements, typically 30 minutes after you have the food. So it's just having smaller amounts or choosing the lactose-free products. And then high fiber foods you may need to avoid as well during a flare. And we do recommend making the changes one at a time. Instead of cutting out all of those things, just checking to see what works for you, because you might not need to avoid all of them. So what is fiber? Fiber is the part of plant foods that we as humans do not break down. There's a lot of benefits associated with it, including preventing diverticular disease, relieving constipation, preventing colorectal cancer. The list goes on. It can help lower your blood sugar and lower blood cholesterol, and of course regulate bowel movements. You may need a low-fiber diet in certain conditions, such as for symptom control during a flare. If you have a stricture or narrowing of the intestine, you may need to limit some, or if there's a partial obstruction. And I know what you're thinking is, isn't a low-fiber diet unhealthy? A lot of people ask me this, and honestly, when you're having these symptoms, we just want you to feel better as soon as possible. So fiber is classified usually based on its solubility, that is, its ability to dissolve in water. So there's two kinds. We have our soluble fiber, also what I refer to as our soft fiber. If you put this in water, it would form a gel. So picture a gel going down through your intestine. It's soft, it's safe, it's okay. It can help bulk up stools, minimize diarrhea, and it is actually broken down by bacteria in the colon to produce what they call short-chain fatty acids, which are actually really beneficial to your colon. Your colon likes it. It gives it energy, it helps promote water and electrolyte absorption, like potassium. Insoluble fiber is the tough, coarse fiber, stimulates bowel movements, prevents constipation, sometimes not well tolerated during a flare, but in general, if you're tolerating it, it's great to have in your diet. So sources of soluble fiber, we have our soft vegetables and fruits, things like bananas, avocados, cooked carrots, cooked squash, potatoes, again, without the skin. Grain products, things like oatmeal, barley, rice, especially the stickier the rice, the better. So if you like to make things like risotto, that's a good thing to have. Smooth nut butters, so it could be peanut butter or almond or cashew, but as long as it's smooth, that's a good source. And there are fiber supplements that exist, things like Benefiber, which has inulin as its soluble fiber source. That comes from chicory root. And then there's Prodium and Metamucil, which have psyllium as their soluble fiber source. And you may have seen psyllium added to things like All Bran, Bran Buds, but the bran is your insoluble fiber. So typically with the vegetables and fruits that have a lot of seeds, your berries, tomatoes, cucumbers, and the skins as well. So if you're having an apple with the skin or a pear with the skin, that would be your insoluble fiber. Whole grains, or you think brown bread, brown rice, and quinoa. And then whole nuts and seeds, as well as legumes. So if you're having chickpeas, kidney beans, lentils, those are all sources of the insoluble fiber. And a lot of foods will have both of them. So if you have the apple or pear again, the skin has the tough fiber, whereas the inside has the soluble, the soft fiber. So the risk for malnutrition is increased, especially during a flare, for several different reasons. Loss of appetite is common, especially when there is inflammation. You may be having gastrointestinal symptoms that are worse after you eat. That can definitely limit intake. Things like fatigue, gas and bloating, pain. Loss of nutrients can occur. So if you are having a lot of loose bowel movements, you may be becoming dehydrated or losing salt and potassium. Or if you're losing blood, you may be at risk of iron deficiency. And then medication side effects, such as nausea and vomiting, can occur. Malabsorption, it really depends on where in the body it is and how much and how severe it is. So in the small intestine, that's where we absorb the majority of our vitamins and minerals, whereas the colon, the large intestine, is where water and electrolytes like sodium and potassium are absorbed. And elimination diets, so for people avoiding foods or even whole food groups and doing that in the long term, you can become deficient over time, especially if you're not supplementing appropriately. So again, common nutrient deficiencies, it really depends on where. If it's the small intestine, you're definitely going to have risk of more nutrient deficiencies. Not to say that it's preventable, that you can't supplement, just something to be aware of. So things like zinc, vitamin A, minerals like iron and calcium, and vitamin D, vitamin B12 as well. And protein and energy, especially during a flare, you just need more to heal and to watch out for your hydration, making sure that you're getting enough fluids. So many forms of nutrition supplementation exist. We have the liquid nutritional supplements. You may have already seen them in the store, things like Ensure or Boost. There are a lot of different kinds though, a lot of no-name brands like President's Choice that are just as good. They are very high in protein and energy. They have a lot of vitamins and minerals. They tend to be lactose-free and gluten-free. They do have a lot of additives as well though, which some people prefer to avoid. So in those cases, I would strongly recommend, if you have a blender, just to make your own smoothies and then just take a multivitamin at the side. Enteral nutrition refers to food, so if there's things like tube feeding, you have a semi-flexible tube that goes into the stomach or the small intestine. And a lot of research has been done with this, and particularly in Crohn's, it has been shown to help induce remission, particularly of the small bowel, and especially in children, in which you want to limit the use of steroids because that can stunt growth. Parenteral nutrition is when liquid nutrition is going directly through the IV into the blood. This is completely bypassing your whole gastrointestinal system, and it's really used in the most extreme cases when your gut's really not working. So if there's a fistula, a complete obstruction, or something like short bowel syndrome, where you don't have enough intestine to absorb enough nutrients. It has not been shown to induce remission. So there are certain medications that it can interfere with the nutrition. Sulfasalazine and methotrexate can both limit the absorption of folic acid. So folic acid comes from the word foliage, so then it's naturally found in your vegetables and fruits, typically the dark green and orange ones. For people who are taking these medications, we do recommend the supplementation of 400 micrograms per day, which is the amount that you would find in your usual multivite with minerals. Corticosteroids like prednisone increase your needs for calcium, vitamin D, and protein. So what they actually do with the calcium is they decrease the absorption of calcium in the intestine, and they increase the urinary excretion of calcium. So it's just important that you're getting enough either from food or supplements. The calcium, we recommend 1,000 to 1,500 milligrams a day, and vitamin D is 800 to 1,000 units a day. So vitamin D is harder to get, especially in our northern climates. Just to give you an idea, 1 cup of milk has 100 units of vitamin D. There are other food sources, and the sun, you get some from the sun as well. But it's just important to know that you might need some supplementation. Cholestyramine is a medication that is given in certain cases of diarrhea. With long-term use, this can lead to deficiencies of our fat-soluble vitamins, so vitamin A, D, E, and K. Other medications like sulfasalazine, methotrexate, metronidazole, also known as Flagyl, can cause some GI symptoms like nausea, vomiting, or even dyspepsia. Omega-3 fats are heart-healthy fats that have been shown to have anti-inflammatory properties. So a lot of research is being done in IBD, but they haven't proven anything yet. A lot of studies are just too small or they're not long-term enough. There is some evidence that it can prevent the development of ulcerative colitis, but again, they're still doing a lot of research. That being said, there's still benefits to having the omega-3 fats, whether you have IBD or not. It's very heart healthy. And the best sources come from our marine sources. So think your fatty fish like salmon, tuna, trout, mackerel, and things like sardines and anchovies. Certain vegetable oils will have omega-3s like canola oil, flaxseed oil, walnuts, even avocado oil or avocados, and hemp and chia seeds, which can easily be added to things like hot cereal or yogurt. And we do recommend choosing the food sources of fish oils as much as you can. So for home, we recommend continuing to eat a variety of foods from all the food groups as much as you can. Please keep a food and symptom journal. It just really helps individualize and make the plan right for you. And when you are in remission, remember to reintroduce foods that may not have been tolerated during a flare. It could have been just a temporary thing, and we don't want you to become more and more restrictive, especially if you don't need to be. And of course, I recommend talking to a dietitian. So if you're in the community or even in the hospital, just ask to talk to one to see, even if it's just to ask a few questions or to get into more depth. We're definitely there as a resource, and we try to provide the most scientific-based evidence that there is. And as Gail spoke about, there is the SOS Cuisine meal plan. It's for people in remission, and it just has a lot of meal plans, meal ideas that can be helpful too. And thank you very much.